We're doing a bit of a panel discussion, so if anyone has any questions, Sandy and myself will walk around with the microphones. In terms of the Avastin, I know that you said you like the Avastin and you use it. When do you routinely, yourself and Helen, when do you routinely sort of initiate that?
Is that on? I think it's probably more of a question for James.
I'm just curious down in Sydney how often
Look, I think it's as long as it's used in the right setting. So it's not on the PBS, as we said, for after initial diagnosis. It's got its disadvantages, and that's around, its placement around surgery timing. But in my experience, I think it's a pretty good drug. I've seen some Lazarus resurrections on it, and when we first started using it, it put you in a bit of a place where you thought, wow, this person's come really good for a while. But the problem is that it gives you can give you excellent quality of life. So I've seen situations where people will come in, they've got a recurrence of their tumour, they've already had all of their initial treatment, the tumour's come back and it's causing a lot of symptomatic problems, and the only thing to get control of those problems, the nausea, vomiting, headaches, seizures, whatever's going on, mobility changes, is the steroids, which can cause problems in themselves. And I've seen people that have had a dose of Avastin and next day they're up and walking out of hospital. So I've seen some good things. And for me as a nurse, I think that, if we can get people back to good quality of life and they're back out on the golf field or, engaging with their family and getting on with good quality of life, that's way better than, anything else that you can provide for people. So it's got its place. I think it's a good drug, used in the right circumstances. Yeah. Do you want to add anything?
Oh, yeah.
Get it.
So, I would just expand and just say that I would only really consider it in people who can't get off dexamethasone. I think it's got a great role in actually getting people off of that drug, because the longer you're on it, the more problems you're going to end up with. But if dexamethasone works, makes you feel better, and we can get you off of it, then we obviously save a significant financial cost.
My question's in relation to, I guess, a comment that Mark made at the start about quickening up the research sort of effort and getting results out quicker. If you go to the other end of the spectrum, this is my question, is how do we quicken up the diagnosis? And if I can use my wife as an example, she had 6 years of treatment for something that was being diagnosed as heart-related. And it was only after a very severe seizure that they went to the brain. And I'm just thinking that if we could quicken that process up, we wouldn't be at the other end trying to find quicker results for the research, which is probably not as essential in her case as it may be for others.
Absolutely right. Unfortunately, by the time we actually find these things, it's too late, unlike with other types of cancers. There is some research going into kind of circulating biomarkers of disease, and what I mean by that is actual blood tests looking at signs of cancer. Most of those are happening in other types of cancers, though there is some increasing evidence of it in GBMs. But I don't know if it's going to expand into the setting of diagnosis as opposed to the point of view of actually monitoring disease while on treatment and stuff. But that's certainly of interest. But I think we're a little ways away from that, I'm afraid to say.
A lot of it comes back to your GP picking things up, and brain cancer can mimic other diseases, and so it becomes quite difficult. I saw a patient recently who'd been investigated for ear pain, and 99 times out of 100 it's going to be just a middle ear infection or a cold or something else, but they had a tumour. And so it's, I think our GPs are trained very well, but sometimes, these mimics are there, and thinking that something is a brain tumour is also a bit awkward. but rarely these sorts of issues where you've been waiting for 6 years to get into something come to the fore. It's unfortunate when it happens, but yeah, no, rarely it does happen.
Hi, my question's about Avastin also. If you want to start Avastin to be able to get off dexamethasone permanently, do you have to stay on it for the swelling to stay away, or if a couple of sessions of it makes the swelling disappear, can you just stop?
It's an excellent question. I have no idea. Usually the people who respond, we tend to continue. But in my patients who've responded for periods of time, I always end up factoring in breaks anyway. The Avastin can be given once every 2 weeks, once every 3 weeks. Sometimes people actually want to get away, or there's some issue where they miss a dose. Have I ever seen a dramatic deterioration when they've missed doses? No. But I feel when the going's good, and especially after they get past the initial cost bit, we tend to say, well, look, it's now paid for by the drug company, so let's continue. I have been in the situation where a patient's gone abroad multiple times and missed multiple doses. Did that really affect him? Probably not, but it's really difficult to. That's my experience. I don't know.
Yep. I don't think there's any right or wrong answer there. There have been a couple of studies for radiation necrosis, so the swelling that you get after treatment, radiation, where I think there's been 2 studies, and they've just given 3 or 4 doses of a flat dose of 400 milligrams regardless of your weight, and literally given those 3 doses, calm down the effects from the radiation, you're off the steroid and stop it. And we've done that with a few people, and there's haven't been any issues after that where the swellings rebound and come back. But I think it's around where you are in your treatment journey. So if you've got a tumour that's grown despite all other treatments, you probably need to continue it. But if you're in other situations where you've got a lot of swelling there as a result potentially of treatment, maybe a couple of doses you can get away with and stop it. But, you need to, it's looking at the big picture. It's sort of not just one thing.
Okay, thank you.
My question is for Dr. Hanson. So going into an operation, do you, looking at a tumour, can you sort of tell what stage it's at, and which stage is it that it then becomes malignant?
That's a good question. Look, unfortunately I get to see thousands of MRI scans, and so I can pretty much pick up probably 90% of the time I'll have an idea of what tumour I'm dealing with. And that's generally whether it's benign or malignant. GBM often looks like GBM, and so that you know that something's malignant, whereas a low-grade glioma looks like low-grade glioma. The time that really becomes difficult, like that cystic tumour I showed that had a solid component and a cystic component, so that can be hard to know the difference. And the other ones are, and it's not just the way that an MRI looks, it's the age of the patient. I kind of get a bit of an idea of which tumours are going to turn up in a patient that's 60 or as a patient that's 10, and the way that something looks on imaging. The ones that are difficult are the patient that's kind of in the middle, like age-wise, sex-wise, and they might have something that looks low-grade, but there's a couple of spots in it that can be bright, and they might be high-grade spots. And so sometimes I'm looking at taking out just that high-grade spot to have a look at what things are. So, 90% of the time I probably know what it is before I'm going in.
And probably in adding that, maybe often the history, if it's a short history of symptoms, we may be looking at something that's higher grade because it's grown a lot quicker than a low grade tumour.
Hi, my question's to Dr. Hansen. I had a benign brain tumour and I'm on Keppra, and I'm just finding it a dreadful drug. So I've managed to take half a dose now, and I'm still finding it's doesn't suit my body. And I wouldn't mind getting another opinion about how important you think it is for a patient to be on Keppra.
Yep, that's a good question too. There's some great drugs, and James will talk about those, or he has talked about those. But look, Keppra is not for everybody, and there's a whole number of different anti-epileptics. So at the end of the day, we're trying to stop seizures, so it's for seizure control. And Keppra is a relatively new drug. When I first started my training, basically everybody got phenytoin. And if your Keppra is not working for you, there's a number of different other options you can try. Carbamazepine, sodium valproate, phenytoin. There's a whole range of different drugs that can be tried to try and get your symptoms under control. So unless you've tried all of those other drugs and the Kepra's not working for you, then you're probably better off speaking to your GP in the first place, and you could try one of the other medications. So you could start that. So rather than going cold turkey off Keppra and then starting something else, you're probably better off having a slight time where you're on both, but you can change to a different drug. So you can talk to your GPs, and GPs are actually pretty good at looking at that. Neurologists are also very good to talk to, so you can get a referral to a neurologist to look after anti-seizure medication. Your neurosurgeon can look after it as well. Just as I said, we're not very bright, so it's probably better off going to somebody else. But your GP is a great first point of call, and you should be able to change off your Keppra onto something else.
Can I just follow through? How long do you think a patient should be on Keppra after a benign brain tumour?
So benign brain tumours can act aggressively. So by that I mean they can grow in funny spots and they can cause some symptoms. So somebody with a benign meningioma, for example, that can grow over the motor strip and then cause weakness and basically not, like you've had a stroke on one side of the body. A benign brain tumour or a low-grade tumour in the wrong spot can cause ongoing seizures. If you haven't had a seizure for years, then often you can try to come off an anti-epileptic. One problem, though, is driving and your lifestyle choices. If you have a seizure and you're off your medication, then it's 12 months until you can drive again. So some people would prefer not to take the risk of coming off an anti-epileptic and then lose the ability to drive for 12 months because, a lot of people find not driving a big problem. So if you had a seizure on presentation, although it sounds like you had 6 years of trouble, but if you had a seizure on presentation, you had surgery, and then you haven't had a seizure afterwards, I'd generally give people a trial of not being on an anti-epileptic, depending on... there's a lot of little depending-ons along there, but you don't always need to stay on an anti-epileptic for life, but you can have a conversation with your surgeon, your neurologist, or your GP as to what you should do. But certainly there's a lot of drugs out there to try for seizure management, and they don't all have this... They've got different side effect profiles for different people.
Do all malignant tumours have roots? Like, is that the thing that makes it... Not the thing that makes it cancer, but
Yeah. So when I describe a malignant tumour to patients, I talk about an octopus. So I say that I can get the head and the body of the octopus, but there's always the tentacles, and that's where James and radiation type people come in to try and mop up the tentacles that come out. So GBM, for example, has more the tentacles coming out. And whilst most of the time, if you get a recurrence, it's in the same spot that it was, it can pop up elsewhere. If it's something like a melanoma, then it's running around in your bloodstream and then penetrates into the brain and then pops up in your brain in places. So what becomes malignant is that it's coming from somewhere else. So yeah, that's the way I describe tumours to people.
Hi. We were told, I don't know whether it was my wife's situation at the time, but we were given Avastin as a sort of a choice, but we're then told you're probably better off going on a holiday. What would be your thought on that?
That difficult to comment on that. Our job when we recommend things is to do just that, recommend. We should be offering all the viable options, but it's not our job to make the decision for you unless you're asking for something that we truly think will make you worse rather than better. With regards to any sort of drug, we have to balance the effectiveness and the side effects, and that can include financial toxicity and stuff like that. It's difficult when you're in the situation where you're trying to offer something, but you don't know how well it's going to work. One, that it will cause significant problems. Two, and what people's wishes might be in that. Do you want to end up coming into hospital every 2 weeks or 3 weeks, have the nurses trying to find a vein, sitting on a chair for an hour and a half, 30 minutes, traveling to and from hospital? Or would you rather avoid that and spend quality time somewhere else outside of the medical facility? I would have never put it in that sort of in those words as what you might have received. But no treatment is always an option and should always be presented as an option. And when I say no treatment, it's like avoiding side effects, if that makes sense.
Okay.
For starters, Marina, James and Mitch, thank you for attending. My question's directed towards Mitch. I had a grade 4 malignant GBM cut out earlier this year. I suppose my question is probably more for my own personal knowledge. If it grows back, is the potential for it to grow back again be aggressive and malignant, or is the potential for it to be benign and as less of a problem as what it created originally?
Can I start by saying that's the best tie I've ever seen in my life? That is fantastic. It's a okay. Okay. James wears some out there gear, but you've got nothing. That's great.
You can work in clinic.
Yeah. It's a good question. So the underlying tumour that grows back is still a malignant tumour. So it's an aggressive tumour. It grows back. Often when it grows back as a recurrence, it seems to grow more rapidly than what it did the first time round, often. But often when I've done the original surgery, I've given you space. So part of that is a part of the surgical thing that I do is to give you space, because the skull's a box and the brain's soft, and then your tumour that's growing expands, and it's not going to expand your skull. What it does is push on the brain, and that causes issues. So part of the philosophy of the surgery is to make more space so that if the tumour grows back, it's less likely to put more pressure on the brain until it gets to a certain size. So recurrence can grow back, and you might not have any symptoms that it's grown back like it did the first time when it was there. And that's why we do regular MRIs along the way, because you've often got the space for the tumour to grow back into. So, I said earlier that benign tumours can act aggressively, aggressive tumours can act benignly. So if it's growing back into a space and it's not pushing on anything, you won't know that it's necessarily there. So that's why we follow up with scans and we keep an eye on things as it comes back. So I hope that answers your question.
Absolutely. I also did, for my own benefit, check through my medical records when I got released. I have one last question, and it's actually worth a carton of grog. I would really like to know how many stitches I had down there.
On the skin or inside?
Either or either, because I think if I can better 47 in total, I'm going to win a carton of booze.
Well, you would have only had one.
Unfortunately, I've already lied and told them I had like 300, and I've already drunk the carton.
Just a question. If there's a GBM removed from the rear of the right rear, and there's been 6 weeks of radiation therapy combined with chemo, and how long would you, and which has been, the side effects have been very good through all of that, how long would you expect generally for the confusion to take to start to disappear after that, if there is such an answer?
Really don't know.
For mechanical tasks I'm talking about. No.
So one of the funny things about the acute phase after chemoradiation, so within the first 3 months after chemoradiation, very commonly things can look worse on a scan, as in we can see a significant growth of either the tumor or an increase in the swelling. That can obviously cause symptoms. Commonly, we don't know whether that's due to the actual treatment working really well and killing off the cancer and that death causing the swelling versus the cancer growing. This can always complicate things in that kind of when are things going to start getting better or worse sort of situation. The other thing is that with what I tell people with chemotherapy, and this is specific to chemotherapy and not necessarily radiotherapy, is that it's actually pretty rare for people for their symptoms to improve on chemotherapy from a neurological perspective. Chemotherapy doesn't tend to shrink tumors. It tends to hold them at bay. And so if the cancer is not being shrunk, then the symptoms won't necessarily improve. It's not always the case, but that's the general way.
My name's Vicky. I'm from actually way north of Kempsey, up near Bellingen. So Dr. Hansen has spread himself around quite a lot in New South Wales.
Don't publish that.
I guess my question is for the three of you, and if we all become your ambassadors and we were able to elect next Saturday a politician who would direct a lot more funding to brain cancer research, what would be your favourite thing, or what would be the thing you think needs the most funding going towards? Where should we be heading?
Good question. So for me, being a nurse and being a care coordinator, and to plug things a little bit, when I first started in my job, I was the only care coordinator for neuro-oncology in the state. And, personally, and as the girls that have come on board over the last few years with the supports, and it hasn't really been governmental support. So my role is supported by the Brain Cancer Group, who are down in Sydney, the girls here, Mark Hughes Foundation. So, and I think from a health or medical perspective, the Cancer Institute, when they hand out the money for different roles, the breast cancer, the lung cancer, the bowel cancer gets it. But because we're the smaller tumour group, the funding hasn't been there historically. So that would be a big thing that I'd love to see, that every hospital in Sydney had a brain tumour care coordinator to support people, because of all cancers, it's I think one of the hardest. It really impacts the patient with, changes in memory, cognition, mood, big change to your life, relationships, ability to work, drive, all of those things. And that knock-on then affects the patients, the families, and the carers. It's, of all cancers, it's got the highest carer burden. And a lot of what we do is really supporting the carers, in that emotional support. I can spend a lot of time on the phone just trying to support people, who are doing it hard when they're the partner or main carer for a patient. So for me personally, I'd love to see that funding. Some of the biggest hospitals in Sydney haven't got a care coordinator, and I see people that come from other areas and they're floundering, So I know I'm in the role, but that's something I'd love to see.
Yeah, I totally agree. I think one of the biggest differences in the last few years is the Mark Hughes Care Cover. It's drastically changed how well our patients are managed. Unfortunately, we're not very good, us doctors, at looking after our patients in the same way that Sandy and Alicia and Marina are. With regards to research, what would I like to see? I'd like to see investment in the newer generation of drugs looking at harnessing the immune system to attack the cancers. There's a lot of interest in that, but brain tumors behave very differently to all other types of cancers, as everyone in this room probably realizes. And I'd like to see us trying to figure out how to stop the octopus from spreading its tentacles. That would be the other big thing that I would be interested in seeing. There's some evidence that there's certain factors which cause that, and working on how to figure out to reverse or block those factors.
What they said.
A robot. Yeah.
Hi, my name's Melissa. I had a pineal tumour removed last year in April, and I just wanted to know, with the funding, like the surgery in itself cost $102,000, and what happens if it was to come back again?
That's really difficult.
Sorry.
No, don't be sorry at all.
Yeah.
I'm very sorry for you. As I said, for the last 5 years in Newcastle, there's been the option for private surgery and public surgery. And I said that there's no difference between the care that you will get in the public hospital or the private hospital.
Yeah, it's just because they think that the pineal, like the actual tumour in itself, doesn't do any symptoms. But I had the symptoms for 2 years until I begged my doctor to give me a CT. They kept putting it to anxiety.
It's more the you do not have to pay for world-class neurosurgical care in the Hunter. When I look after a patient with brain cancer, I don't charge a gap because cancer kind of sucks. And I think you've already got enough burden on you, so I don't actually charge a deficit in the private. And in the public hospital, if your tumour is difficult, yes, it's a teaching institution, but the consultant will be doing your case. There's a number of people in the media that come across and say that they are the best surgeon in Australia, and I would dispute that. because I think the care that you can get for free in the public hospital, no out of pocket, is world class in Newcastle. So I don't think you need. You should not be $1 out of pocket when it comes to public care.
Can you please put your hands together for Dr. Hanson, Dr. Lynham and Marina? To get each and every one of you through your journey, we work in a huge team, and these are just a few that are part of that team, and we are incredibly lucky in the Hunter region to have world-class multidisciplinary teams. So honestly, it's a pleasure to have you today, and we really appreciate your time. We know you've all got busy schedules, so we truly appreciate it.